All right. Well, Jen, thanks for the introduction, and many thanks to the team for the invitation to share some discussion with you this morning at this early session. These are my disclosures. I am the MUSC Principal Investigator for the ALIVE study. So I think as everybody in the room knows, the bigger the LV, the worse the outcomes. We have lots of studies to suggest that. Here in this early study from 1997, we can see that the larger the LV, here measured by the end-systolic volume index, the higher the risk of heart failure hospitalizations as well as mortality. And this is really true even in patients who do not have severe symptoms. Now, Jim Udelson and colleagues also have shown us that if we can reduce the LV size with therapies, these patients tend to have better outcomes. So here in this study, showing that if your end-diastolic volume reduces with therapy and your end-systolic volume reduces with therapy, those are the blue dots, those individuals have a reduction in mortality compared to those who remain enlarged. And of course, we have the STITCH study, which was surgical ventricular reconstruction that did not overall have positive outcomes. Yet, as we do with so many studies, we take a look at subgroups to see who potentially would benefit from these therapies. And it's probably not surprising to any of you, those individuals who had more reduction in LV size actually did better. So on the left-hand side here, if the individuals had a reduction in their LV end-systolic volume index to less than 60 milliliters per meter squared, you can see their mortality at follow-up was about 10% compared to upwards of 30% in those individuals that did not achieve that reduction in volume. And on the right-hand side, just showing that the relative change in LV size, if your LV end-systolic volume index reduced by more than 30, your outcomes were better. So I was asked to discuss our first patient in our study, and this was a 66-year-old gentleman with an ischemic cardiomyopathy. He had diabetes with severe neuropathy. He initially presented with new onset atrial fibrillation. His ejection fraction was found to be about 30 to 35% at that time. He had a stress test that was markedly positive, and he, at an outside institution, underwent multivessel PCI to the LAD, diagonal, and RCA. 3 months later, unfortunately, he had an anterior ST elevation MI and had another PCI to the LAD. After that, over the next few months, he really worsened. He had 2 heart failure hospitalizations. He had difficulty tolerating guideline-directed medical therapy due to hypotension and worsening renal function. Given his continued heart failure symptoms, he was referred to me for further evaluation. At that time, he was on a medium-dose beta blocker. He was truly intolerant of an ARNI as well as an aldosterone antagonist. So when I saw the patient, he had a modestly low blood pressure, heart rate was 64. He was markedly volume overloaded, as you might expect. JVP was elevated to the jawline. He had significant lower extremity edema. And this was his echocardiogram, ejection fraction of 31%. The left ventricular end-diastolic dimension quite enlarged at 7.5 centimeters, and he had anterior septal and apical akinesis. So I ended up admitting him for IV diuresis and an evaluation for advanced heart failure therapies given the severity of his symptoms and overall trajectory. We were able to diurese him 24 pounds and get him back onto some medical therapy. And after that, we repeated a right heart catheterization that showed we were successful for the most part in getting the fluid off. His right atrial pressure had normalized, but he still had an elevated wedge pressure and a reduced cardiac index at 1.7. And despite this optimization, he really still had class 3 symptoms. Cardiac CT was done, showing an ejection fraction of 30% and really, again, huge LV volumes with myocardial thinning and evidence of scar in the mid and apical segments, along with decreased contractility. And here's that CT scan. You can see that the apex there is somewhat dyskinesis with evidence of scar. So now what do we do for the patient? And of course, we get the patient on guideline-directed medical therapy, and after diuresis, we're able to get him at least on modest doses of our quadruple therapy with beta blockers, ARNIs, aldosterone antagonists, and SGLT2 inhibitors. We thought about an evaluation for a heart transplant or a left ventricular assist device, but he had severe neuropathy from his diabetes, a relative contraindication to transplant. He was probably, actually fits nicely into the treatment gap that Dr. Calger described earlier, that he's not quite sick enough for an LVAD. And frankly, he told me, Doc, I just don't want that. So what else can you offer me? And so we offered him enrollment in the ALIVE study. This here is his CT scan with the inward displacement analysis that Dr. Puri described for us. You can see the dyskinesis at the apex, but evidence actually of a pretty good reserve, if you will, in the basal and mid walls. So we enrolled this gentleman in the live study, had successful anterior apical aneurysm plication via a small left anterior thoracotomy and right internal jugular access. He had a significant and immediate reduction in LV size. And then I recently saw him in 6-month follow-up. He was euvolemic on exam. He was now tolerating guideline-directed medical therapy, and he had improved his functional class, being class 2. This is his follow-up 6-month echocardiogram. Again, you can see the left ventricular size smaller, and these are the actual results compared to baseline. Probably a modest improvement in ejection fraction, but the left ventricular end-diastolic and end-systolic volumes had declined dramatically. And overall, a 42% reduction on end-systolic volume index. Again, probably a good prognostic sign. So when I first heard about this study, I said, well, I think this is a good idea. We know from Stitch that there certainly is a group of individuals that could benefit, and perhaps if we could do this in a less invasive manner, we would not have the same morbidity and mortality associated with a surgical procedure. But I have to be a little bit honest with you. I thought I might be looking a little bit for a needle in a haystack. So, would I really have a lot of these patients in my clinic that would benefit from this type of therapy? Because, you have to have anterior scar and maybe a little bit of an aneurysm. And as my wife would tell you, I'm often wrong. And so, it truly is more common than I thought. I'm reminded that the burden of ischemic heart disease is actually only growing in the United States. Here, looking at total heart attacks as well as total ST elevation MI. And as Jen showed you earlier, about a fifth of patients who have an MI will develop heart failure within 5 years, and a significant number of those individuals will have post-infarct remodeling. And I think, unfortunately, over the last 2 years, we're only going to see this burden grow. So this is a case report we published in the European Heart Journal of an individual who had a delayed presentation of an ST elevation MI due to COVID, and he developed a VSD. Obviously not appropriate for this therapy, but that being said, I think we're going to see more and more of these individuals who have perhaps large anterior ST elevation MIs that present late and may benefit from a therapy like this. So I'm reminded as now we've enrolled a number of patients, and I actually look for this therapy, and you really won't find it unless you're looking for it. And I think a good example of that is amyloid, right? So if you think back kind of 10 years ago, we weren't really thinking about amyloid. Now it's something that we think about all the time in our patients with HFpEF. We know it's actually pretty common. And so when we're looking for it, we actually find it. And I've been really surprised at the number of patients I've seen who actually fit the inclusion criteria for this study. And I think it makes it all even better if we have a potential therapy for it. And so that's obviously what we're studying in this study. But with the approval of tafamidis for amyloid now, we have a therapy we can offer these patients. And perhaps we'll find with the live study, we have a therapy for these patients as well. So to summarize, LV enlargement is a marker of poor prognosis. But if we can reduce LV size with therapy, this is good. Live therapy was designed to less invasively exclude LV scar and positively remodel the LV. The prevalence of ischemic heart disease is growing. Our preventative cardiologists have a little bit of work to do. But patients meeting inclusion criteria for the study may be more common than you think. They've certainly been more common than I thought. And I'm truly excited to see the results of the pivotal study. So thanks again for the invitation, and look forward to the discussion this morning.
Thank you.